us started because we have a jam-packed presentation today. Welcome everyone to our second webinar for this year, and with Dr. Bethell, Christina Bethell. Just quick reminders, you all should be muted when you enter, but feel free to introduce yourself via the chat and share your camera. We'd love to see you. And it gives Dr. Bethell a way to react and interact with you all as well. So you're staring at a black screen.
Yeah, I love to see your beautiful faces.
Thank you. So let me just briefly introduce Dr. Bethell, and then I'll turn it over to you. So,
okay, great.
Christina Bethell is a national leader in the development of policy, practice, and research applications of population health and systems performance measurement and family and community-centered improvement methods. She's a founding director, and we'll talk a lot today about her Cami, her Child and Adolescent Health Measurement Initiative, and the National Data Resource Center for Child and Adolescent Health, excuse me. She has a lot of experience working with national, state, and local implementation of child, family, and community health and health systems performance measurement tools. So hopefully will be incredibly helpful in thinking about your early childhood comprehensive system initiative. So I will turn this over to you, Dr. Bethell.
Great. Okay, I was given a big charge. So I do have a lot to share, but I'm going to leave you with, oops, sorry, let me get up to the top. I'm going to leave you with resources. And I've been aware of the amazing and bold work of ECCS for years, and I'm really glad to be able to talk with you and also invite you to put things in the chat, especially if as I'm going, there's something really that sparks you to let me know, okay? So I'm going to go ahead and get started. First of all, just to let you know a little bit about the Cami. We've actually been around for 26 years. At the beginning, our work was really focused on even creating measures to identify kids with special needs or developmental screening, the CAPS tool. There wasn't really data when we got started, but the Medicaid CHIP program really sparked the need to do that under the Government Performance and Results Act, which requires all federal programs to measure and report on performance in some way. So that's kind of how we got started. And our whole focus was on family-driven, family community-driven, lifting family and community voice, looking at outcomes, and with the goal to just define what do we mean by positive health outcomes and how can we discern and develop data that can be used for transformational partnerships. So the whole work is around how can we support groups like yours. And the purpose is really to translate the science of healthy development, which was strong back then even, and is even stronger now, and requires those integrated systems approaches and always has. So we want to find ways to penetrate through the barriers because it's been a common need and understood a common need for a very, very long time. The way I like to approach it is to start where we want to end up at those outcomes and then work from there. So for me, that's child flourishing. It's not getting rid of something bad, it's promoting something good, and you'll run into the risks as you do that, but flipping the narrative to proactively promote what I call positive health equity. So we want health equity for positive things like school readiness and success, flourishing, which can be defined and we can measure it, family resilience, having hope and strength to draw on, because this is the bedrock from which all other things sprout in our communities and in our homes and in our systems. And here we are with, even though we have well visits, let's say paid for at least all states, and we have recommendations and regulations, only about half of the estimated well visits for children in the youngest years actually take place. Most children have at least one, but most of the visits that are supposed to happen don't actually happen. So we have this opportunity. And even though we've had policy performance measurement for a long, long time on developmental screening, it's only 1 in 3. And the first time we measured it back in 2007, it was 19%. So we put so much resources in. And so clearly there's something going on with how we can really optimize the feasibility. There's something going on, right? We need some tools. We need a new way to make it easier, because it's not the case that the people in the field don't care, but something else is going on. And only 2 in 5 are ready for school, no matter how we slice and dice and how generously we score it. When we really look at early learning skills and social emotional development, and also those, self-regulation capacities, if we look at all 3 and score it pretty generously in terms of kids, it's about 2 in 5 across the country meeting these criteria. So the opportunity is great. And finally, experiencing social and relational health risks, which I separate out, and our research has separated out or studied whether they can be separated out. And I'll tell you a little bit more, but when we look at the social risks that we know are on board and try to figure out what are the systems, integrated systems we need to create, it's important to understand a little bit more about this. So I'm just going to show you research results from three studies, and then I'm going to go right into talking about frameworks and measurement and data related to this. So this is from a study that really was looking at social determinants of health and whether we should just bundle them all up, like food insecurity and experiences of racism, neighborhood violence, economic hardship, and ACEs, and just sort of how do they play out. But if you look at the science, some of the mechanisms are very particular around the relational health risks in particular. So I just looked at that for children with mental, emotional, behavioral problems in the country and by state. So we have this data for state. So right down here, you'll see kids that don't have any of those social risks that I just named, and none of the relational risks. About 15.3% have a mental, emotional, behavioral problem. If we add in one relational health risk, it's about 18.5 with no social risk. If we add in two or more of those relational health risks, it almost triples. And so that was new information to me. It was a study after all. And the pattern continued across the continuum of social risk, that it really started to bump up when we have both social risk with relational risk. And there's a lot of variation in how children do with social risk based on whether we have these relational risks on board. And it's all children as well. So there are many without the social risk. About 60% with relational health risk don't have social risk. So to me, this means we want a high risk approach, but we also very much want to look at the health of the whole population and not make assumptions. This sort of played out again in an earlier study, actually preliminary, looking at family resilience and parent-child connection, which of course also speaks to creating the social container for which families can be resilient and connected within. And you don't have to look at all this, but this will be the last more complex slide, or maybe the next to last. Just look at these little red circles. And this is kids with no ACEs, for example, and they don't have that going on. But if they're missing the family resilience and connection, they're much less likely to flourish, be ready for school, things like that. So I think it's important, again, that it's not just that relational risks are different than social risks, speaking to the nature of the integrated systems we might need, but even without some of those risks, without proactively promoting the positive and those capacities that we're built for, but can get really under-optimized in the environments we're in, we miss a lot of opportunities. So some of the things in the family resilience measure that we created are really basic things like having a sense of hope, feeling like you have strength to draw on. And we know that if we have families and children who are experiencing social risk and even have resources to support them, that sometimes if we don't have hope, don't see strengths, aren't inclined to reach out for help when we have problems or stay connected and ask for support, it can be really difficult to get that uptake even on all the great resources that we're actually offering. And about half of children in the country experienced high levels of family resilience and connection when this study was done, and it's about the same now. The last piece from a science point of view that I want to leave you with was this curiosity that I had about positive childhood experiences, noticing that there's huge variation in how children do when they have adverse childhood experiences. And while they're more likely to have all kinds of problems, most don't. So there's a lot of kids who are actually experiencing adversity who are doing better than others. What can we learn about that? And again, we looked at creating and validating a positive childhood experiences indicator and whether it operated independently or not. And basically what we found was that these were adults looking back on their life, so it was analogous to the ACEs study, that people who had more of these positive childhood experiences, which can co-occur and do co-occur with ACEs, that we can actually do something about in the community, in our schools and in our homes, that there was a 72% lower odds of having depression as an adult, and there were other outcomes we looked at too. So basically, this is a part of the flourishing paradigm and part of why I'm so focused on that. So with all of this research and the policy opportunities, we had the opportunity to work with Mississippi Thrive, which was a 5-year, ended up being a 5-year project through the SPRANS granting program with HRSA. And we really brought together all the key partners that they had assembled to create a framework that we ended up calling the Engagement in Action Framework. If you're interested in the blow by blow, how we got there, what the background was, you can go to the Engagement in Action Framework website. Probably just type in Engagement in Action Framework Cami, because I'm not sure Google's catching it. But there's about 5 attachments that go into a lot more detail about how we got here. But basically the purpose is positive health equity, like I talked with you about, which is a different way to anchor a purpose in terms of measuring. And we have some measures for this, but they're not in any of our performance indicators yet. And the framework goals really at a high level, which we can break down, are all children are receiving universal provision of comprehensive personalized whole child and family preventive and developmental services, leveraging the guidelines we have, but through any door. And then real engagement. We have, we do a lot of taking of data from families, and we do a lot of hopes for engagement. We don't really have tools or mechanisms to operationalize that and make it real. So that's a big focus. And then also seamless system, which is our all of us are working toward, but just really delineating more the partners that are there, what their different roles could be, what their current obligations are and performance measures are that could be leveraged to bring them in more, and how we can start to really create the movement that we need, because we already have the passion and the goals, right? There's an approach to care that is defined, that is centered on this through any door family engagement concept and the universal provision, but with resources and tools to help make that come alive across the different partners that might be the access points for the families. I'll talk a little bit more about that in a minute. It also has an implementation roadmap that is, it's high level, but it's still a lot. And it's really focused around the need to establish those sustainable cross-system, multi-level state leadership capacities that you're all working on, talking a little bit more about different pieces of that, creating a culture of engagement, which we need to take very seriously because we don't currently have that. Our systems aren't there. We haven't necessarily been trained, but we're moving along well. But that's for families and providers and so on. And catalyze and facilitate the study and spread of cross-sector practice-based implementation that change needs support, a learning community. And we've known that for a long time, but often we sort of come up short in really supporting the transformation process and connecting people who are independently trying to do that with each other to really get the bang for the buck that's needed. And that's a sustainable resource that's needed to create change. And then finally, driving and enabling incentivizing policies and financing strategies. We have 21 specific policy levers that were defined and discussed, and that's one of the attachments on the website that you can read very humbly, because once you define it enough, then of course the details need to come, and hopefully that's where we can all go from here if you're interested. So I just stayed on that slide, but I'm going to share these slides so you can have more information where I break it down a little bit more just visually for you so you can take a bigger look. But I'm going to stick here for just a second that whenever we want to change a complex system, which inherently means that there's real-time decision-making happening every moment, and you can't control that. But if you have some simple rules that everyone agrees to, it can be very helpful. And this is just from the complex adaptive systems literature. So we call them simple rules, but they're also just principles for collaborative action, where everyone really sees themselves as the leader that they are, and that they are making a bigger difference and they matter more than they think. Everyone at every level who's interacting with a family or each other in the system. So really taking on that leadership role and seeing all the things that you can leverage, big or small, to be part of the solution, that everyone through any door sees that. And it's true that statutorily wise, most of the systems that you're trying to engage, I think, have an obligation to do things like screening and connecting to primary care and, really trying to promote well-being of children and families. So there really needs to be a collaborative approach so that everyone can partner together in every encounter, being that presence that can create safety and connection and care, because our brains, as you know, are wired for that. And when that isn't there, and it isn't there all the time, the trust that we need to be able to engage families authentically and to really support them in each other is often not showing up. So this is a very important part of it, is in every encounter to be that presence. And those are skills as well that we have to work on. And then finally, just a habit of no broken link, that whenever somebody leaves my presence, there's a somewhere I know they're going, or the family has a link, so that we don't just drop the mic on our families. And finally, to make sure that we have some kind of feedback loop that really gives us the information on how we're doing. And so these are some of the things that need to be in place. And we've been working for decades actually on trying to put some of the tools together for that I'll share a little bit more about. And so I shared the implementation roadmap. These are the 21 policy levers split into financial and non-financial levers that Medicaid can use with managed care health plans, because that's so much of where the resources go, and then it moves from there in many ways. And then other cross-agency and strategic levers. So this is humbly put forward, but these are the ones that we really honed in on in Mississippi and are sharing them with you through the website. Another piece that we did that was a lot more work than I thought it was going to be when we started was really characterizing and understanding all the different partners and where their current goals were, mission was, capacities, their statutory obligations, their performance measures, and what that did to where they might actually already need to be playing a role and how to engage them. And so this is just a diagram that comes with a long description, which is attachment C on the website, looking at community-based resource organizations, federal and state funded agencies and programs, the healthcare system itself, and all these are linked, in the county and local, looking at 25 different partners that are probably pretty generic across a lot of states, although the names will change, the categories probably won't, and going through and assigning them different priority roles and what the relevance was. And so in attachment C, we delineate this a lot more, but it's helpful to see it on one page. It was hard to put it on one page. I can't tell you, like, it looks really simple now, but if this is helpful to you, it's an offering also through the ENACT framework, which is its nickname is ENACT. The last part that you might find useful is stories. So we know how important stories are to inspire and be able to see ourselves in things. And so we worked with different partners in the state to create these short little, what we call possibility prototypes, looking at what was emerging through the ENACT framework and seeing what's working now in these systems already, say primary care or the Help Me Grow program or early intervention, and what's the opportunity for improving on current goals and obligations even by the ENACT approach. How might that start to move and what would be needed for success? So they're short, but they're supposed to jumpstart the process of thinking through how that approach might be working in our different partnership groups. And again, the through any door model is really what came through. That if we don't have a way to meet families through any door with some kind of a somewhat standardized way to engage them in a comprehensive assessment that isn't just developmental screening on its own or autism screening on its own or maternal depression screening on its own, but really seeing the whole child and family, and that the family sees it too, that we're going to have a hard time really achieving the vision that we have for an integrated approach that we already all know that we want. I will say there is a toolkit that came out of the Mississippi work where we partnered closely on this toolkit that you can click on the different pieces. This is on the Mississippi Thrive website. So if you just, it's also on our website, you can click right to it, where you can get access to information about the resources that are featured. But in your state, those resources might be different, but this is what was put forward because this is what was going on in Mississippi, and I think would have some relevance for most of the states here as well. So one of the key pieces that sort of powers elements of this, of the ENACT framework is something we've been working on for actually over 20 years, called the cycle of engagement, which is a theory or a model that the Cami has operated from for a long time. And we've operationalized this model for early childhood development through a set of tools called the Well Visit Planner approach to care. And it's I can tell you a lot more. There's some videos, but the basic idea is that child and family services focused on building trust, personalizing care to family-defined strengths, needs, and priorities, and an integrated whole child and family assessment, producing tailored results in the moment and resources that can be shared with families and also empower professionals to be able to go right to the issues and not have to spend all the time just collecting information and looking for resources. Will build partnership. It actually saves time to deepen relationships and address each child and family's unique goals, needs, and priorities, which we want, and foster ongoing engagement to continuously update that agenda so that we can continuously support families on their journey to well-being, and that this will result in measurable improvements in child health equity, flourishing, as well as more joy for families and providers. And it's hard out there, so we want to really bring joy to this if we can. So much more to say, but this is a theory of action. And I'm going to start going a little bit more quick here because these are resources you're going to want to read a little bit more about. And I'm giving you all that information in the slides, or we can pull out a separate sort of cheat sheet for you to click on links. But the basic cycle of engagement model for young children is using a pre-visit planning tool, the Well Visit Planner, that we've worked very closely with the AAP and family organizations to create. And then that empowers a personalized connected encounter, which I described a little bit before, and then having this way to periodically assess quality using the online Promoting Healthy Development Survey, which has actually been around since 1997. It's been updated for Bright Futures. It's been endorsed by the National Quality Forum and produces automatically data for families and providers aggregate on the quality of care, so you can get feedback and also empower even families to know what to expect and what's happening, and they can start to really partner in the improvement of services for their children in the community. This is just a little picture of the Well Visit Planner tailored for ages starting 3 to 5 years of age, 3 to 5 days of age to 1 month, 2 months, and every single tool is different. So it's 15 different tools that are very age specific. Those of you who know the guidelines know that it's very complex. It's very hard to figure it out. You can't really expect even a pediatrician, let alone a family physician or somebody working in the community, to be able to memorize these things. So this, you don't have to. You just have to, go along and it's valid and you get the results, and then you can start working with families. We did have a study done on this, which has been randomized controlled trial supported through HRSA. So this is something we're offering. But Mathematica did an independent evaluation, really looking at how these tools might be used through the leadership of community and family organizations to basically build anti-racism and to amplify community voices, advance health equity, and address structural racism, especially with the data that comes out, can be used at a population level. So this is just a high level of these resources. There's videos. They can be used tomorrow or built in over time. And these are just some pictures of what it looks like. So basically, going to the Cycle of Engagement website, one can sign up, start to use this with families, and there's a data sharing platform that allows, say, a home visitor to share the data with the pediatrician and that sort of thing, which is very important to create for real the types of systems integration that we want. That this is a key piece that we keep landing on and that has really driven our work over the last couple decades. Okay, so now I'm going to give you another angle, which I think is really important, because all this is great, but if we don't have performance measures and things we're held accountable and get rewarded for, it can be very hard to get the attention to create change. So we run the maternal and child health measurement compendium and have created it along with a measurement agenda for years. And the goal we have is to create sort of what we call swamping the system with aligned measurement. So we have national, state, local health plans and pediatrics, family medicine, community-based organizations and services. And then we have down to children and families. So that's our goal. And to create shared accountability. So if all we did was get really focused on developmental screening, maternal depression screening, and promoting positive outcomes and just honed in on that, we would create a big difference. So where are we with our different early childhood systems? So we did an analysis recently, just updating all the measures because they do change year to year. So we have to keep them updated in our database. And basically what we found is there's about 309 specific measures that are used across these 6 partners, which is Medicaid CHIP, and then HEDIS is for health plan measurement specifically. It has the most measures that are child and family related. McV, home visiting, community health centers, FQHC, Title V, early intervention, and hang on a second, and I've got my picture over it, child welfare. So these 6 actually have reportable measures. There are others that have standards, but they're not reported in a standardized way, and so we couldn't analyze. But there's 71 topics, so 309 measures across 71 topics. So already you know there's overlap, right? So where do they fall in the realm? So about 17% are in the area of access and utilization. Like, did you even have a visit? You know, did you get prenatal care? Did you get, well visits? Those sorts of things. Do you have adequate insurance? Really basic, very important. Quality of care all around screening, referral, and follow-up, because the point of screening is to go all the way through. About 23.6% of the measures are in that bucket. And about 15.5 are in quality of care. And we put actually medical home there because our measure of medical home nationally is very comprehensive. It's not just having a provider. It's really the whole comprehensive set of factors that are outlined in the initial AAP definition that are operationalized. And then finally, health and intermediate outcomes, which was where the largest bucket was. But most of those outcome measures are actually Title V measures. There's a lot of outcome measures in Title V. So going a little further, like, okay, how can we figure out where the opportunity points are for leverage? And that would be more of the systems that need to come together, share something in common. And so there are 13 of those 71 topical areas that are shared across 3 or more programs. They're listed here on the left according to the group they fall in. A is access and utilization, B is screening, referral, and follow-up, C is quality of care related, and then D is the outcomes. And so basically the 2 that are really across all were depression screening and prenatal and postpartum care, okay? And developmental screening will come online in 2024 with also FQHCs being held accountable for that. So then we have Medicaid CHIP, HEDIS, Title V, FQHCs, and McV. So that's a lot of overlap and, that can start to bring people in. It's still screening. It's not necessarily outcomes, but I wanted you to know this. It was a lot of work to get it down to the nitty gritty, but when we then map all of these back to the ENACT framework, almost all of them are aligned across agencies. Of the topical areas are aligned, and that there's a lot of things we can act on now just by even making people aware of this and maybe even aligning some of the ways we share the data. So there's 3 other programs we also examined: WIC, Head Start, and Child Care and Development Fund, which is early care and education. All of them do have standards, all involving engaging families, conducting comprehensive screenings and assessments, making sure kids get primary care. It's all over the place for all of them. Some have a little, like WIC is more, of course, focused on breastfeeding, but that's also a part of everything else. So there's real opportunities here. They're just not created as measured with a numerator, a denominator that's reported. So in the ENACT framework, appendices C, you'll see a lot more detail about these 3, but they're also equally relevant. They just haven't moved up to sort of a metric level that we can then decipher and pick apart. So our initial recommendations on measurement, which is very key, because if we don't attach things to measurement, we're in some ways not putting it at the priority level we need. First of all, to optimize the current data being collected, share it across the systems. It's there, but it's often not shared. And some of the measures are a little bit different, but they need to come together so we can see the picture of our system, especially in the areas where we're all collecting some of the same topics. And then also to leverage that local data collection. And the Well Visit Planner and PHDS are tools that could give you local needs assessment data or local quality of care data where it's not national and state, or even geographic, but it's for whoever you're actually caring for. And that's really important bottom-up data that you're going to want and need and act on. And providers and professionals get so excited, as do families, when they see their data back about them. And so that's one of the big motivating factors for the Cami is top-down data in action, like national, state, local, but bottom-up data in action, where we start to use similar metrics, but they're coming up right from families and your local services. Then aligning measures. There's some opportunities where measures are close, but no cigar, like they're close measuring the same thing, but not quite. And when they're exactly the same, that can be very powerful. But there's even ways to start to harmonize how they're reported, even if they're not the same, because we can adjust for how they're different. So aligning measures intentionally in states, I think, is really important. Oversampling, which is almost always an option to allow for more stratifications by race, ethnicity, income, and things like that, and adding qualitative data, having a habit of sort of getting that qualitative data also in to tell the full story of performance and opportunities. So this is just a picture of the website you can go to, and I'm not going to go through it, but it's very intuitive. If you want to start looking up these measures yourself, we do the synthesis separately, which I'm sharing with you today, but you can actually go program by program and see the depth and the detail, including Healthy People 2030, for those of you who are working in counties and are looking at Healthy People 2030. So the last segment that I'm going to talk with you about is leveraging existing data to jumpstart at any conversations or to continue conversations you're already having. This is ultimately from the National Survey of Children's Health. Like I said in the beginning, when I started, there wasn't a National Survey of Children's Health or special healthcare needs. There wasn't even a way to measure that. So we really want to recognize the incredible leadership of the Maternal and Child Health Bureau. Actually, for everything that I have shown you has come through the Maternal and Child Health Bureau support. Certainly other agencies as well, ACF, Department of Ed, CMS, ARC, but the big push has come through HRSA. So all these resources I'm telling you about are really related to HRSA, where your funding is also coming from. So let me just give you a little preamble, which is wherever we are on the transformational change journey, we know we need a knowledge base. We know we need a social strategy to bring people together, and we need political will. And what's the common denominator for all of those is data. We need information and to blend it with our stories in order to bring people together, even to create a shared vision, to start to build trust that we're talking about the same thing, to build commitment and movement and inform the detailed actions that we need to take. So this is just a little way that I think of the importance of data as we go through the transformational change process that we know we all are going through. So this is a website you can use, childhealthdata.org. If you're not familiar with it, you get to go on and just pick which data years you want, what geographic area you're interested in. It could be your state or the nation, and then start to learn about the data if you want to, or go right in to request a data set, because we make the data sets coded, cleaned, anyone can use them. And there's thousands and thousands of articles that get published because people didn't have to spend a year and get a $500,000 grant to get the data, clean the data, hire a university to do it. So we cut out the middleman as much as we can and really, really empower you to either access data findings right here, get summaries in comparison tables or US maps, or actually just get the data set and do some things beyond what we can share on this type of resource. So I want to make sure you know about it. Big categories related to early childhood, and the early childhood data is actually a little more difficult because there's not as many kids 0 to 5, and you sometimes want to really subset it for that. So I'm actually finishing up creating a lookup table that just puts out these data variables for 0 to 5, which I know you need, because it doesn't help you as much if you have these variables for kids all the way up to 17. So that's a big part of the work we did for the Engagement and Action Framework project, but also want to make it available to all states, and we'll be doing that. There's a lot on the website, but this special analysis is something that we need to do on the back end because it has a lot of technical pieces to it. So there's these categories, and I won't tell you all about them because what I'd rather do is speak specifically to the opportunities to start using this today to look at equity. And so there's 3 examples I want to show you. The first is looking at prevalence. So what's the difference in the prevalence of something across different population groups of children? And I'm just picking race, ethnicity here. And so this is looking at ACEs, children with adverse childhood experiences, and you can click on these boxes to find out what's in that, how it's measured, right? So you get the automatic data, how is it measured, what's it made up of, and then you get the measure. And then you click a subgroup. You can pick your area and a subgroup. There's many subgroups. The list is pretty long, but one of the subgroups is race, ethnicity. And then you're getting race, ethnicity as a subgroup, and this tells you the differences in prevalence based on race, ethnicity. So you're looking at 2 or more adverse childhood experiences, 19%, 16.3%, and 25.4%. Now, this may make you curious, and you may want to go request that data set because you want to unbundle it a little more, but this is a lot. You can use a lot of this to write grants, to put presentations together. You can copy and download the table and do odds ratios if you want with it. It will go right into Excel. And we also give you a graphical display that you can copy and paste into your PowerPoint. So we're trying to really empower you as much as possible to use this data. And this is just one example, but this is looking at prevalence and how does it vary. The next is different. And it's not used a lot, but it's very powerful possibility right now, which is what is the distribution of children with a specific issue by, say, race or ethnicity? Is it disproportionate? So we know a certain proportion of children are in each group. Let's say 17% are Black children. Are Black children disproportionately represented among a specific topic? That other analysis wouldn't show you that. So what you do here is you actually go to the demographics right here. You're looking at the demographic race, you're looking at race, ethnicity distribution, and the subgroup now is adverse childhood experiences. So before it was race, ethnicity was the subgroup. Now race, ethnicity is the main group and ACEs is the subgroup, okay? So that's the main measure. And this tells you something slightly different that's equally important. I always like to combine both because you want to say the prevalence is this, and that represents a disproportionate share. Because sometimes the prevalence is varied, but it doesn't represent a disproportionate share. So hang in there with me. This is just basically telling you the proportion of children with 2 or more ACEs down here that are in each race ethnicity group. So 10% are in the other, 18.2% Black, 45.5% white, non-Hispanic, and 26.1%. So if you're interested in population health, you don't only want to look at the highest risk group. You want to look at everyone. So from my read, the bulk of the children with this risk are white children mostly. And that can be powerful in bringing in all the partners to see this is all of us. If you also start stratifying by public or private insurance, you'd be surprised what you see, or income, that it's not as variable on certain measures as you would think, especially on the positive health indicators. So if it's useful to you to know this so that you can start to bring in it's all of us conversation, you already have the data to show we know it's disparate. We know it's worse here, and that's not good. But depending on what you're trying to do in your systems integration work, you want to everyone see that they're a part of this. And so this is a really important way to use the Data Resource Center right now today. There's a video on there that shows you how to use it. And if you have a question, just email our info box, which is very evident online. The last thing is comparing all states. Now, you're a team of states that are trying to help each other by coming together. So it might be useful for you to look at all this data and see how you vary, because there's huge variation across states, that is not explained by just controlling for certain demographic factors, which I have mixed feelings about doing anyway. But you'll be able to see, oh, okay, we have really better in this state than that state. Let's talk to each other. Let's see what we're doing. What are the policies? What are the practices? Why might that be? huge variation in developmental screening. So using this resource to help you see what's going on across the country today is very powerful. And I'm just going to fly through some slides and you can look at them later, looking at, the kind of variations that we see and some of the measures like low birth weight, special healthcare needs, parents who are not in excellent or very good health problems. And look at these state ranges down here, 36 to 52 for parents and caregivers, one or two caregivers in a home not being in great mental health. Experiencing one or more risks on what we have as an integrated child risk index, which integrates social, relational, and developmental and special needs. And you can see this variation across states. So doesn't that make you curious? One or more adverse childhood experiences, a large variation as well. So as I go through these, just put your eye down here at the bottom, and you're going to see the state variation. And then I have another analysis I don't have time to show you, which is the variation within the variation. So if you look at, say, Utah, you're going to see lower rates of a lot of issues. But if you look at Utah by race and ethnicity, they are off the charts with disparities in that area that wouldn't be found if you didn't look a little deeper. So you want to look at the disparities, but you've got to at least maybe leverage this data for your own work to see where you're already seeing higher rates. So look at this back to sleep at 35% range across the state. So that's also very empowering. And then because this data is collected yearly, you can do some things to start to track it and see if things make a difference. I was in Oregon for a lot of years, and we were one of the first states to get developmental screening paid for and included as a performance measure. And also North Carolina has done a lot of work. And to this day, North Carolina and Oregon have done a lot of policy work, and they tend to be higher year after year. So it really makes a difference what we do. It does show up in the data. And hopefully that's also inspiring that we have power, we have things we can do. So just a few more, like this is prevalence of families that are receiving food or cash assistance, adequate insurance, emergency room, whether they have an individualized family service or IEP, special needs. This is very interesting, the IEP, because we know we have high risk, but sometimes low IEP, which tells us that the services are probably not adequate. That data can be used to bring in early intervention potentially, or help them with their child find work, and so on. So I'm going to end with a short course in making data come alive. Just a few tips that might be helpful to you. The first is, we all know good enough data. Okay, we're not talking perfection, because if you work too closely with data, you know there is no perfect data, literally no perfect data. Not even an HbA1c diabetes test is perfect. So that's relevant, valid, credible, and actionable. So what does it mean for something to be actionable? When you start looking at it, you move forward a little bit, you're interested in it, you want to know more. People have to be inspired to create change. It's hard. So you want to look for those things that will start to create that engagement. But it has to be communicated in the right way at the right time to the right people. And these sorts of things can start to become a habit, but if you've not done it as much before, it can seem overwhelming. So I want to give you a few examples. The first is, I like to categorize it, I call it the data menu, the hors d'oeuvres. Now, lots of things we measure in our programs are characteristics of the population, how many people walked in the door, basic satisfaction. Probably doesn't really get you going that much, but it's important, and usually you have to report on it. Processes of care get a little more exciting. What's actually happening? What's happening because that's happening? Are there changes? And then ultimately, are we actually seeing some of these changes attributable to what we're doing? That's also often in the realm of research, but you can collect the data in a way that can help you in real time. And then, of course, the main course we like to say is health outcomes attributed to what you're doing in a valid way. So there is data available to you right now that can be used for that. The second little tip area is, first of all, that purpose drives measurement. If your purpose is to improve, you've got a lower bar, but you need things everyone in the improvement team agrees to measure in the same way and do it rapid fire. But this is just a table you can look at how systems improvement is different in terms of how you might track it than, say, quality improvement or public accountability measurement, and so on. So this is a table that you can look at more at the whole talk just to go through it. But my tips are to plan ahead. Spend that uncomfortable time really thinking, maybe without even looking at anything here, say, what do I want to know? What do I really want to know? And then start to do the math on what you could actually measure. So being intentional before you dive in so that you have a light to guide you, because it gets overwhelming. I always say wherever two or more variables are together, it is overwhelming. Like you can do so much with data, you can do so much in this area. So think about what you really want to know and let that be your guide. Don't fill up on hors d'oeuvres. Don't get so excited when the early data you get is all this stuff and try to make meaning out of something that might not have the meaning. So do it. You have to have it, but don't fill up on hors d'oeuvres, spending all your time on that. Keep going. And I say, don't get caught by fast food data that's not really data. It's actually, if it's not striking you as useful or actionable, it's probably fast food data. It's there, but it's not really telling you what you need to know. It's very important to know that. Don't order more than you can eat. If you get something and you can move with it and it's met your intention, move with it, because you can get lost here. And so just keeping that in mind, that don't order more than you can eat, and know when you're full. There is a point where more data is not better. It's not going to create more action. Just be at the watch of that. You know, it could be great. And I have to watch myself here because I go into the little rabbit hole of data all the time. I'm like, you know, it did its job. And then maybe I'll go back and get more if we need it. Let the process push your data at some point so that you don't get so caught up in data that you don't have any time to actually collaborate, you know, which can happen. It can happen that we have all this data, but nothing's really happening relationally in the system. So making sure to that. So these are some of my little mantras. One is, what's a measure? So standardized measurement allows us to compare, which creates learning. This is just right. So if I have something and you have something and we did it the same way, even if there's wind coming up the pathway and we're both riding a bike, we have the same wind. So we can still compare our time, right? I'm riding a bike, you're riding a bike, there's a bias called wind. So I'm not going as fast, but I had it and you had it. So I can still compare. So sometimes very imperfect data can still be used for comparison because we had the same biases. And so it still can be used for learning. And I really want to encourage not having perfection all the time. But a measure has usually a denominator. Children who are a numerator have this thing, a clearly specified measurement strategy. And that's why things like the National Survey of Children's Health and even the Well Visit Planner or PHDS that I shared earlier are standardized, built with families, but standardized so that you don't have to worry about that piece. And then have a clear scoring. So data measures are not data until they're scored and reported in a way they can be understood. So we don't just stop at getting it, which it's sitting in a lot of systems in our state agencies right now, but it's not coming out. It's not being scored meaningfully. There's a lot of ways to score data that are much more powerful than we report on. And even if they're reported, it's internal or to your funder, it's not to the system. So I'm recommending trying to bring it all on the table, bring that data out that you have so rich, a lot of rich data already, and start to look at it together as a team. And making it come alive is just the last little tip I have, which is turning it into something that's familiar. So school buses, let's say, how many school buses filled with children have special healthcare needs? And so, you know, here it's 13.8 million children in the United States had special healthcare needs, which would fill up this many school buses. There's, you can have 40 kids in the school bus with 55 feet for the school bus. And this would be 1,637 miles and would stretch between Washington, D.C. and Denver. So you can take the data and turn it into something that's really understandable. And I've had a lot of experiences with like school superintendents or anyone in the community understanding data when you start to communicate it a little bit differently. And even small numbers are big. So if you have small numbers, you're looking at kids 0 to 5, it's usually still a lot of kids that actually need something. And even if the confidence interval is wide on your data, you can say, well, 4,000 to 8,000 families in our state needed respite care and didn't get it. And when that happened, those families had to cut back or stop working. And so those are the kind of things you can do. So this cut back and stop working one is an important measure due to a child's health issues. And so this is 2.1 million children with special healthcare needs have parents who had to cut back and stop working. This is the number of people who work for the entire US federal government. So these are just some examples to maybe start to whet your imagination about how to report information in terms that people can really, really relate to. And this is just another example from California this is Maryland. I used to be in California. Where I was working with the Maryland folks about, how many children across Maryland would be represented by special needs. And then you can start to break it down by, say, publicly insured children or privately insured children or uninsured children or white children or non-white children. And that's just really interesting because you get more miles often with non-white children, but they're not the majority of the population. So for this variable, there's a lot of disproportionate share from that earlier example I showed you. Even if the prevalence isn't very different, which it is, but they don't always go together, but I won't go into that. So together we can do big things, that, you're leading that. And also it really relates to how you are. So a lot of people I've been talking with these days aren't feeling like they're really flourishing. They're trying to help kids and families, but the burdened themselves. And so just really to say that the most important person in creating change is you. And every moment makes a difference. Every interaction creates a reaction. We're neurobiological relational creatures. So it's really these systems change. Our relational systems of care is what we need. They're built on those moment by moment relationships. So to just really bring your own well-being into the realm, to know how much it matters and how much you matter, and how much every moment matters when building this capacity for systems change that can be sustained, because it not only lives on paper and in our data, but it lives within our hearts and in our relationships. And that is hard to get rid of when you've got it in that cultural, relational way. So I'm going to just say we shall become flourishing facilitators. We're going to meet a lot of difficult things along the way. But basically, if I identify as really seeking the positive, it turns it enough that it brings more motivation, I think, and shared commitment. And I just invite you, if you'd like, to look a little bit more about the engagement and action framework humbly. There's much more we could do, but you can see a summary of it and all these resources I've been interweaving throughout, and just leave you with a quote: that tomorrow belongs to those of us who conceive of it as belonging to everyone, who lend the best of ourselves to it, and with joy. So that's my presentation. I hope we have a few minutes left for questions.
Thank you, Dr. Bethell. I'll say we are a small, it was a great presentation. If folks have questions, please feel free to unmute or type them in the chat box. We do have a few minutes left for that. While you're thinking of those, I'll just share that Becca did put the evaluation survey in the chat link. So we'll ask you all to spend a few moments completing that as well.
Yeah. And I am curious how this lands on you. So that's valuable too, just as feedback from the field. So any questions or feedback?
Well, I'll just say I was impressed. You covered so much in the presentation, and it was different pieces that kind of sat with me. One piece, when you talked about the CQI measures and for learning versus accountability, and we worked on some measures in our CQI group, and I was working with another administrator. It was like, are you doing something else? And it's like, this is where we're starting for now, but we'll have an opportunity to come back to add some others. But like, as a group, we did work on some shared measures that we wanted to learn and look from, and we'll look at for a course of time and then come back and say, what do we want to do next? So that was helpful, just in reiterating some of those processes. And you said a lot of key quotes that my colleague Nicole and I were like capturing. She captures, they resonated with us, that we'll take with us. But great presentation. Thank you so much.
You're welcome, Erica. I'd love to hear more as you go forward. Nicole, did you have a question, or you just, nope?
I was just responding. It was Erica and I. We were going back and forth in teams, just,
Okay, great, good. Yeah. Well, I mean, maybe we can just take a breath. I do know that was a lot. I was charged with a lot, but hopefully you were able to see the threads between the pieces, and, just maybe just sit for a second and see if there is any either feedback or ways to make this more useful to you, or a question or
Christine,
comment? Yeah, go ahead.
As folks are thinking, first of all, thank you so much. And it's really been such a joy to witness the progression, within Mississippi and the national opportunities that have emerged from this work. I don't know, while folks are thinking about questions, if you might want to also share the kind of data that emerges from the well visit planner and the PhDS survey that might be helpful as well.
Okay, let me actually get something that can do that. I didn't put it in the slides because I didn't want to overwhelm.
Yeah.
But I'll just, first of all, did anyone have a question while I'm going to grab this, or no? Okay. So I'm just going to go ahead and share from a document because I didn't actually include the details in the slides. I was already concerned about how long they were. But let's just go here. And how many of you, I don't know if you're going to be able to answer that, but are familiar with the Bright Futures guidelines and the recommendations for screening at each age, and also topics that are particularly important for education, which vary also between the first week of life, the 1 month of life, and so on. It's a lot to remember. And so the Well Visit Planner actually covers a lot of different sectors aligned with the guidelines. The first is looking at strengths. So families get an opportunity to share what's going well for them, what's going well for their child. Providers love this. It's really a good way to start off an encounter, is celebrating strengths. And also, if it's difficult to do that also gives you the opportunity to be sensitive. Open-ended questions about concerns or goals before we start asking families about what specifically they want, screeners, just give them a chance to see what's actually within them that they want help with, to make sure we don't miss that. And then going through developmental surveillance, we use the SWIC, which has been validated against the ASQ as being equally or more valid. The MCHAT for autism. Questions in the guidelines are definitely asking about any concerns about speaking, vision, or hearing, additional concerns, certainly caregiver depression, varying between the PHQ-2 and then, of course, the EPDS for postpartum. And family psychosocial issues, not overwhelming families with questions about this, but getting some of the really basic things, and families don't have to respond if they don't want to, if they don't feel like responding, that's up to them. And that allows you to be sensitive to families that may not feel comfortable sharing something. But if they do share it, then you get to scooch right up and say, hey, you shared this. Would you like to talk about it? Is there what do you think should be done? What resources do you already have I can support you in? Do you want more? So it becomes about them and them inviting you in on their agenda. Anticipatory guidance can be 36 things for some ages. Families don't even know what to expect, so we probe them and they learn in a very simple way the categories and topics, and they can learn about them as they go, popping up little educational sheets, and then really hone in on the time during encounters, whether it's with their home visitor or with their pediatrician, to focus in on what's important. And the average number of families pick is 3. So they're not picking everything. And a lot of providers are scared about that, but you got all the screens, you met their priorities, and you really save that time in the time when you're with families to focus on what's important to them while also getting the information you need for screening. So there's optional assessments you can add in as well if there's something that goes beyond the guidelines. Sorry, this is a document that has a few comments in it, apparently. The Promoting Healthy Development survey actually has been around a lot longer than the PHDS or the Well Visit Planner, because it was used to assess the quality of well childcare. It was used in the National Survey of Early Childhood Health, 13 Medicaid programs. It's been used extensively. It's really looking at whether anticipatory guidance and parental education needs were met. Recommended developmental surveillance and screening occurred, follow-up for that as well. We have a follow-up measure, not just did it happen, but was there follow-up. Basic psychosocial screening, looking at family behavioral health and home safety. Was it assessed and discussed, and was it valuable what was discussed, and so on. And then looking at also issues of the community and asking whether that was ever discussed, safety in the community. The core medical home criteria, which you always want to know because we can look at variation on outcomes based on that. And then looking at some parenting practices, but we again don't ask too much in the social determinants or too much in the parenting behaviors, because we're very clear feedback from families that it shouldn't cross the line where it looks like you're evaluating me. And really what you want to do is meet their priorities and then build that trust. And then that will be what leads you to the right thing. So these align with all the Bright Futures indicators of quality for Bright Futures. So using it automatically gets you that, as well as the codes that need to be built for. So that's a little bit more. And then what comes out of this are reports that are like at a glance one pagers and reports with links to resources, both on the WellVisit Planner and the PHDS side. So I'm not sure what you thought of that, but I'd love to know what you think. I'd love for people to share a little bit more if we have like two more. I guess we don't.
We are out of time for today, though if anyone
Okay.
has anything they want to jump in, but if you have questions, after you have some chance, some time to digest this and you want to come back to Dr. Bethell with questions, please, send them to the ECS TAC email and we can absolutely communicate those to her and get you all a response.
Okay, great. Great. And I see some things in the chat. Some of them are directed at me. So will you share those so that I can be responsive? Okay.
Absolutely.
Okay, great. Good.
Thank you all so
Good.
much for joining us today.
Okay.
And thank you to Dr. Bethell for leading this.
Thank you. Thank you. Bye-bye.